Hello, my name is Christia Moby and I work in the product division with Extral. Welcome to today's webcast. I will be the moderator for this event. Today's session will cover the topic of contouring for benign radiotherapy. Interest in low-dose radiotherapy to treat non-malignant conditions, including inflammatory and degenerative disorders of the joints and para-articular soft tissues, has increased substantially in recent years. The clinical efficacy is supported by a large body of evidence, but there is no consensus on the parameters for contouring the PTV. In today's session, we invited Dr. Angel Montero from the Department of Radiation Oncology at the HM Hospital in Madrid to further describe a CT-based contouring atlas for delivering low-dose radiation in the symptomatic treatment of degenerative or inflammatory osteoarticular disease. He developed this atlas with his colleague, Dr. Beatriz Alvarez. Thanks again for your attention, and with that, I'll hand it over to Dr. Montero.
Hello. First of all, I would like to thank to our organizers, to Dr. Schaefer, to Estral, for inviting me to this webinar and to spend the next 20-30 minutes talking about low-dose radiotherapy in non-malignant disorders. Well, everybody knows that radiotherapy is one of the main treatments for cancer and probably one of the most relevant. But probably less people know that radiotherapy could be used for non-malignant disorders, and probably this fact could be scary them in some cases. But this is nothing new. Low-dose radiotherapy or radiotherapy has been used for the treatment of non-malignant disorders from more than 100 years ago, as you can see here on these publications. And a true fact now is that there is a growing interest in the use of radiotherapy for non-malignant disorders, as can be seen in an increasing number of indexed publications regarding this issue. And also because there is an increasing number of guidelines and recommendations about its utility and about, of course, its low risk and safety. Anyway, radiation therapy can be used for a broad spectrum of non-malignant disorders, including skeletal disorders, soft tissue disorders, cardiovascular disorders, brain disorders and functional disorders, and even infections. But I'm going to focus my presentation on degenerative disorders, mainly bones and joints disorders, osteoarthritis, tendinitis, tendinopathies, etc. Why? Because these diseases are of high prevalence, not only in Europe, with more than 15 million new cases each year, but also all around the world. And probably these diseases are rather untreatable. And this is the same just in Spain, where nearly 2/3 of patients are not satisfied with the results of their treatments. Anyway, musculoskeletal disorders are probably the most treated diseases with low-dose radiotherapy, at least in Germany, where more than 80% of cases are corresponding to degenerative disorders or osteoarthritis. And we know that this treatment is really effective, is really useful, and that low-dose radiotherapy achieves high rates of pain relief for every location, sometimes above 19 or nearly 100%. And many people have experienced it. Or, you know, this man, Usain Bolt, is the fastest man on earth, and he underwent radiotherapy for an ankle tendonitis some years ago. Unfortunately, situation in my country, in Spain, is rather disappointing. In a survey we made a couple of years ago, less than 25% of radiation oncology facilities used to treat these musculoskeletal disorders with low-dose radiotherapy. So in this context, why to make an atlas for target volume definition for these diseases? Well, all you know that in radiotherapy there are an atlas for almost every location, and even online tools for target volume definition, as these two you can see here. And also, we have a lot of information regarding from the use of orthovoltage on direct techniques, but much less with the use of Linux or other radiotherapy techniques. And most of knowledge we have of volume definition came from 2D techniques or direct techniques. But there is a broad consensus in that delineation, planning, and treatment procedures for benign diseases should be the same and with the same quality as those used for malignant disorders, at least in the German and British publications. So we decided to make this atlas, and you can download it from this link if you want. And the reasons for that atlas, here are some of these reasons. First of all, because there were no available atlas for this kind of diseases. And our intention was always to make daily practice guideline, more than academic guidelines. And by using resources we have in any radiation oncology department. And above all, an understandable and easy to use guide. But always keep in mind that these are only recommendations and never intended to be mandatory. Obviously, there are other equally valid techniques and procedures for this kind of treatments, but we think that the fundamental thing is to adapt your actions at what you have, because if the only thing you have is a tool, the only tool you have is a hammer, probably all your problems will seem to be nails. But remember that a fool with a tool is still a fool. But before going any further, let me introduce my institution. Our radiation oncology department have two sites in two different hospitals. We have 5 Linacs, 2 CT, Radiotherapy. We are 11 attending physicians with 8 medical physics. We treat about 2,000 new cases each year and about 65, 75 osteoarthritic patients each year. And we have some published experience by using low-dose radiotherapy for the treatment of osteoarthritis, as you can see here. So with that, we decided to follow the same procedure as we have for cancer treatment. First of all, we fixed the treating areas by using masks, vacuum cushions, other kind of cushions, wedges, etc. Then we obtain the CT images at 2 to 5 millimeter thickness, depending upon location. We use the same planning system as we use for cancer radiotherapy, in this case, radio station planning system. And also we decided to make an anatomic correlation with anatomic images taken from the Gray's Anatomy textbook, which is available for free at this address. With all this thing, we finally describe from head to toe how we consider different musculoskeletal PTVs should be delineated, including shoulder, the elbow, including tennis and golf elbow syndromes, hand and wrist, including thumb and finger joint osteoarthritis, pelvis and the hip, including the trochanteric bursitis, the knee, the gonarthritis, defining not only the joint but also the surrounding tissues, as you can see on this slide, on the ankle and foot, including plantar fasciitis, tendonitis, or Achilles tendinopathy, or other tendinopathies. And finally, we include this table summarizing the limits we consider for PTV definition. So in conclusion, these four ideas we thought are most important from that can be taken from this paper regarding to this aspect of the radiotherapy treatments. First of all is that radiation therapy for benign musculoskeletal disorders is an area of growing interest and probably it should be higher in the future. And because there were no atlas for PTB definition for these diseases, we decided to make this atlas based on a CT images, but always keeping in mind that this guide should be taken exclusively as recommendations, never as mandatory. There are other ways to do exactly the same, and these guides are mainly directed to non-practitioners or with non-experienced practitioners, to be sure. And never forget this, as Professor Singer-Smith said more than 20 years ago, these so-called benign diseases may not be so benign as the term suggests. And it's important not to deny them, and it's important to treat them as better as we can. So thanks a lot for this opportunity and open for discussion. Thank you.
Thank you, Dr. Montero. Couple of questions coming in first, Dr. Montero, are around referrals. Could you describe a little bit for us about how you generate referrals and what are some of the barriers to referrals from other specialists?
Well, we started with this program about 6-7 years ago, but talking with mainly with rheumatologists, and we made some previous meetings with them, and because them were very interested in finding any new options for their patients, and I had previous experience in another hospital, and well, talking with them in some occasion, we decided to make a very easy protocol to try to make this treatment possible. It was not only difficult to find other specialists to refer us this kind of patients, but in my opinion, to be honest, the main problem is with our own colleagues, our own specialists of the radiation oncology departments, because you know we are oncologists, so probably it's quite sometimes hard to understand for many oncologists or many radiation oncologists that radiotherapy could be useful for something more than cancer, and that is probably the main barrier for that. But further this, I think the main way to get involved other specialists is to go to the tumor board committees and to comment them not only about cancer but also about other utilities, and to go to with rheumatologists, with orthopedic surgeons, and with other and with general practitioners, of course, and to try to start treating initially patients of advanced ages, patients not candidates for a prosthetic replacement, for a prosthetic surgery, and well, step by step, nothing more than this.
Okay, thank you. Next question, when treating hands with parallel opposed fields, what benefit does the contouring bring?
Well, that's a very good question, a very good point. Uh, well, the reason for doing this atlas of 3D contouring was that we, at least in my institution, we considered that quality of radiation treatment should be the same for every location and should be the same for every kind of treatment. So if we were using 3D definition for cancer, why not use the same quality definition for not cancer disorders? But obviously, if you have enough experience, you can treat these pathologies with only direct techniques or with anterior posterior or posterior anterior techniques without any need to have any atlas for definition. But if if uh, if you have a CT, a dedicated CT in your department, if you want to make these treatments trying to have the same at least quality as you have for other diseases, I think is useful. This atlas could be useful for that purpose. As I have said, this atlas is designed for non-experienced practitioners, obviously. Uh, when we sent this manuscript to be publicated, one of the one of the critics, but one of the opinions or the comments from reviewers was that there were no need for this kind of definition with 3D, with CT images, and so on. And that's right, because if you have enough experience, you don't need it.
Mhm.
But if you want to start to treat this kind of diseases, probably this atlas could be a helpful tool. So these are for them, for us. For me, it's quite interesting for that.
Okay, thank you. Next question. Do you think that radiotherapy could help patients with chronic rheumatoid arthritis?
That's a very good question. Well, um, it has been used for years for that kind of patients, but I think rheumatoid arthritis is a complex disease. It's not only an musculoskeletal disorder. It's more than this. It's probably a systemic disorder, and that's the reason why it is treated usually with now with antibodies and with other advanced drugs. So probably radiotherapy could be a useful tool in these patients for punctual painful joints. But probably this disease is so complex to rely all the treatment on radiation therapy.
Okay, thank you. Next question. Are you aware of any courses or a way to specialize in radiotherapy for benign disease?
I would like to do that. Yes. Mm, I don't know. It's difficult to say. So some years ago, about I think nearly 20 years ago, we made a meeting of the European Radiation Society, the ESTRO, and we tried on this meeting. I was very young then, and I attended this meeting, and I think that the idea of that meeting was to make some recommendations and to try to to make the basement for the development of a core of knowledge for this aspect of the radiation treatment. But probably radiation oncology is now so complex and so advanced that many radiation practitioners or many radiation oncologists have enough work with cancer to be worried about non-tumoral diseases. But obviously, I think there is a growing interest in not only in the use of radiotherapy, not only for this musculoskeletal disorder, but I think there's a wide spectrum of other diseases now, at least in our department, and I think that in other countries it has been the same. We have treated patients with COVID-19 pneumonia with low dose radiotherapy, mainly in the first waves, because there were no efficacy of treatment for this patient, and with a really good result. We have recently published in the German journal our results, and they were really satisfactory for us. And I think the field of radiation therapy for non-malignant disorders is really interesting. I mean, it's not only for musculoskeletal; it's also for vascular disorders, cardiovascular disorders. It's also for functional radiotherapy. I mean, with tremor, with Parkinson, for Alzheimer's disease, and for a lot of diseases that today are difficult, at least, to treat. So I think we must continue on this area. We must continue investigation and research on this utility of radiation therapy for non-malignant disorders, not only as an anecdotal use for osteoarticular disorders, but also for all these new disorders or new pathologies that could be, if not cured, at least relieved with radiation therapy.
Yes, I agree. I also wanted to let everybody know there are a number of presentations available on the Extral website from the
Yeah, I know that.
clinical yeah, the clinical event that we had back in September, if people would like to learn more about
Yes.
benign radiotherapy. I also wanted to let everybody know that there is a new society that is in development, the International Society for Radiotherapy for Benign Conditions. If you'd like additional information, you can visit isrbc.org, isrbc.org. Okay, we have a couple more questions.
And I invite all of interested people to be involved in that new society, because I think is the way to go ahead.
Yes, yeah. Agreed. This is the time to get involved, especially too if you've got thoughts on. Yeah. I know they are looking for additional support as well. So next question, regarding RA, will there be any planning system or CT measurement before the actual treatment?
Planning system. Well, we use the same planning system for all the treatments we made. So probably all the planning systems are useful for that kind of treatment. So it's not necessary to make any investment on nothing special for doing this kind of treatments. The key point is to use what you have. If you have, any planning system, just try to use it. And you have your images, you have your planning system, you have your physicist. So try to use all these resources, and just start to treat.
Okay. Next question, we have time for a couple more. What radiation dose is used for a typical treatment, and how many times a week is it delivered?
Well, we use 3 gray 3 times a week for 6 times. Some years ago, we used 6 gray in 1 gray fraction, 6 fractions on every other day. But following results from randomized trial from from many German groups that compared 3 gray against 6 gray, and with the same results, we decided to change to 3 gray 6 times and on every other day. So our protocol is to initially administer 3 gray in 6 fractions along 2 weeks, and then wait, because response is not response used to be later. So we try to wait for 8-10 weeks to evaluate response. And if after 8-10 weeks pain remain, or a patient feels that the pain is not successfully treated, we repeat the same treatment and we give another 3 grays in 6 fractions. In our own experience with more than 350 patients in the last about 5-6 years, we have an 80% overall, an 80% of clinical response with significant relief of pain according to VAS score, and with improvement in the von Panevich score. But we have to repeat the treatment. We have to administer 2 courses in nearly 50% of patients. So keep it in mind that it's important that if patient has no complete response after the first 3 gray, this not means that there is no reason for the treatment. Probably, if you can give another second course with the same dose about 10-12 weeks apart, probably response will improve.
Okay, thank you. We are coming up on our time, but I do want to get to these last 2 questions. Next question, since there's a planning system, will there be an isocentric shift from the point of interest rather than setting up directly to the field size?
Well, yes. So, about the field size, it's difficult to define exactly which are the limits, and we have we base it to make this atlas. We base it on previous reports from the German and British groups, but it's quite difficult to define exactly which is the right field. But something that should be always remembered is that, and as has been shown in many other previous papers, is that it's necessary not to I mean, it's necessary a field not small enough. I mean, it's necessary. So sometimes the problem with no response is related with a smaller field more than really not utility of radiation therapy. A German group, I think, I can't remember either, but German paper by Kalter and Bonner showed that in the thumb osteoarthritis, a bigger field had better result than a smaller field. So that was the idea we had in mind when designing this atlas.
Okay, thank you. Final question. Do you plan to do any clinical trials exploring benign disease response to radiation therapy? Are there any in the works there at your facility or any others that you're aware of?
Yeah, of course. Now we have some projects on mind. One of the most interesting idea we have now, and we have finishing now the protocol just before discussing it in the corresponding boards, are a protocol for the treatment of Alzheimer's disease with holocranial irradiation, 5 gray, and we have been meeting with neurologists, with pathologists, with radiologists to trying to to initiate this protocol, and we have interest in treating also cardiovascular diseases. I mean, disorders of the cardiac rhythm, and probably for musculoskeletal disorders. I think should be quite interesting. But I don't know if it is possible, but it's idea that sometimes I have considered is, well, all we know that 3 grays are useful and probably are a good dose, but what about to make low dose radiotherapy even lower than 3 grays? I mean, 0.5, 0.3 grays, not only in 2 weeks, but also more protracted. I mean, in 2-3 months, along 2-3 months, could be useful for that. I mean, it is possible to do that and to obtain better results with that. I don't know, but I think that we will need a multi-center trial and probably a multi-institutional and multi-country, if it is possible, trial. So we really, I'm convinced that an international society as the new has been proposed could be the right place to develop these trials and to because this is, I mean, I'm convinced that this is the only way to get better results. So I invite every radiation researcher or even radiation practitioner that is interested in to contribute to this new international society and to propose new trials and to develop new aspects of the use of radiotherapy for non-malignant disorders.
Okay, thank you. On that note, that was a perfect conclusion, Dr. Montero. Thank you again to everyone.
Thank you to you for this opportunity.
As a reminder, if there are any questions, you can reach out to Extral. We will also be sending you a copy of this recording. And if you are interested in learning about other clinical events that we've had on benign radiotherapy, you can just go to our website, go across the top portion of the website into resources, and you can search on benign radiotherapy there on our website. Thank you again for your attention. With that, I will conclude today's session, and I hope that you have a great rest of your day. Thank you so much. Bye-bye.
Bye.